Thank you very much, sir, for this wonderful opportunity. So, my topic today is about emerging infectious uveitis. So, we can divide emerging infections as such into two. One are the newly diagnosed, newly emerging infections, and the others are re emerging infections. And this happens mainly because there is a continuous evolution between the host, pathogen, and the environment. So today we'll be talking about few infections which have been playing an important role in the last 2 to 3 decades, and and we are also going to see how the diagnostic methods have changed over the years. So though these creatures look very tiny and cute, the diseases they cause are quite deadly. So in today's talk, we'll be seeing about rheumatoid granuloma, leptospirosis, West Nile chikungunya, dengue, and a separate entity of mumps virus. So let's rewind a bit. It's the year 1993 in Madurai. There was unusually high rainfall and flooding, and there was a fever outbreak. And a lot of patients were getting admitted in the government hospitals, and they were treated like any other seasonal flu. And few months after that, a lot of patients started walking into a UVA clinic with the complaints of redness, pain, photophobia, and defective vision. Now, the patients were so many, like around 300 patients over a period of 4 to 6 months, and they all presented with anti-uveitis, especially non-granulomatous hypopion uveitis, cortical cataract, veils of vitreous membranes in the posterior segment, disc edema, and vasculitis with peripheral vessel sheathing. Now, in those days, Wikipedia, PubMed, or Google was not even in the era. So it was extensive literature research done by our mentor, Dr. Ratnam Madam. And yet, Madam could not find any uveitis which could fit in all these clinical features. So it was her sheer determination to take the sample, serum sample, all by herself to Chennai, where she had met a veterinary surgeon. And so because someone told that this could be a possibility of leptospirosis because it was already an established disease in the veterinary field. So, as they expected, they ended up finding out that these were caused by spirochetes and the disease was actually leptospirosis. So this is also called the rat fever because it's a major reservoir, and it causes around 58,000 deaths annually worldwide. And the severe form of this disease is the Wales disease, where there is pulmonary hemorrhagic fever or renal failure. Now, the leptospires are present in the urine of these animals, and when the infected urine enter humans, either through intact mucous membrane or through abraded skin, the leptospirosis infection happens. And so the high-risk population were farmers, people who were interested in water sports, adventure sports, and butchers who are dealing with raw meat. And leptospirosis is basically a biphasic illness. There is an early leptospiromic phase and a later immune phase, which occurs 3 to 6 months later. So, uveitis is part of the later immune phase. Investigations, microscopic agglutination test is the gold standard, where the patient's serum is serially diluted and it is made to interact with a 5 to 7 day old leptospira culture. So, this test basically requires maintenance of live leptospires, and the strong infection was considered if there was more than 1:200 dilution. That is the highest dilution, which could agglutinate 50% of the serum, was considered as positive. Other tests include ELISA and PCR. Treatment would be a course of doxycycline, usually for a period of 2 weeks, to reduce the infective load. And the ocular inflammation usually responded very well to topical, periocular, and systemic steroids. Next comes another endemic disease. Several children, mostly young boys, were coming into the UVA clinic with a white lesion in the eye. Now, in those days, when we see a patient with these white lesion, TB was always suspected and they were treated with ATT. But this has been going on for years, but nobody was sure as whether it was really TB. So there was a lot of field work done. A lot of camps were conducted from where the boys the children have come from. And they found out that all of them had a history of taking bath in pond. So the biopsy of the lesion showed that there could be a possibility of a trematode. But again, now this is a dead end because we don't know what trematode is it, nor do we know which reservoir or which mammal or which insect or which creature helped in transmission of the trematode. So that was when molecular diagnostics played a role, and they found out that the trematode was Procerobum varium. So what happens is this trematode, it lives in the conjunctival sac of birds. When the birds come to the lake or pond or water reservoir, they release their eggs, and the eggs hatch and they develop into something called miracidia. Now this for the infects snails, and the snail inside the snail they develop into a form called cercaria. Now this is the form which can enter the human eyes even through an intact cornea. So humans are basically accidental hosts. And the clinical features would be anterior granuloma or subconjunctival granuloma. They can present as granulomatous anteriuveitis, chalazion-like lesions. They can have dense retrocorneal membrane with peripheral anterior synechiae, cataract, glaucoma, and very severe cases could also end up in thiassical. UBM helps us to know the extent of the peripheral anterior synechiae, and blood investigations are done to rule out other infective causes. Histopathology revealed a peculiar splendor Hopili phenomenon where there is a granuloma with tegments or internal fragments of parasites seen. Again, molecular diagnostics are the key, and bidirectional sequencing and blast analysis can identify the trematode up to the species level. Treatment, if they are less than 3 mm, it responds to topical and oral steroids. Larger lesions need surgical removal with in toto excision. Next, the series of infections caused by mosquitoes. West Nile got the name because it was first identified in the West Nile region, Uganda, in 1937. Then in India, as early as 1952, we were able to see cases of West Nile virus transmitted by Culex mosquitoes, and they caused a significant global threat. Warmer temperature, poor water management influences vector population and virus spread. So what happens is when the mosquito bites us, the virus is transmitted during the bite into the skin, and it infects the keratinocytes, Langerhans cells, and dendritic cells. Then from there, it reaches the lymph node, and then to the blood vessel and the peripheral organs. Now, the serious part of the disease happens when it crosses the blood-brain barrier to cause meningoencephalitis, which could be deadly. Patient can present like any other flu, fever, fatigue, joint pain, headache, and facial pigmentation. Posterior segment, we can see disc edema, creamy white retinitis lesions with hard exudates, and sometimes they can also present with vascular occlusion kind of picture. And optic neuritis and chorioretinitis are diagnostic indicators that the West Nile virus can have higher risk of causing meningoencephalitis. In FFA, a peculiar target appearance have also been described where there is central hypofluorescence followed by peripheral hyperfluorescence. Again, Madurai Aravind was one of the very early centers to find out West Nile in India, where the Defense Research and Development Establishment Gwalior helped us in finding out the diagnosis. I'll club the diagnostics and management together for all these virus infections. The next comes chikungunya. It's a single-stranded RNA virus caused by Aedes mosquito, endemic in our country, Asia and Africa. Patient presents with fever, skin rash, myalgia, and lymphadenopathy. And the arthralgia here most often affects the small joints, whereas larger joints are also equally affected, but they prolong in certain patients, and it can be so severe that they will end up needing a hydroxychloroquine or even immunosuppressant and other disease-modifying anti-rheumatoid drugs. And the severe form of this disease can cause meningoencephalitis and fulminant hepatic failure. So in the eye, there can be conjunctivitis, keratitis, episcleritis, multifocal choroiditis, optic neuritis, neuroretinitis, and retrobulbar neuritis. Again, if there is a disc pallor or macular ischemia, there is going to be a poor visual outcome. And the risk of developing the inflammatory polyarthritis has been found to be higher if the initial acute phase lasted longer than 3 weeks. So this is a picture of chikungunya retinitis, and simultaneous occurrence of the eye and the systemic disease suggests that there is possibility of direct viral involvement. So patient can present with ocular features even as early as 1 to 2 days after the fever. There can be simultaneous presentation also. And FFA shows early hypofluorescence followed by late hyperfluorescence at the area of retinitis. And OCT can show hyperreflectivity with some backshadowing and intraretinal fluid. Next is dengue. There are 4 serotypes of dengue, and it has an annual incidence of 100 million. The vector being Aedes aegypti and Aedes albopictus. Again, patient has fever, cough, rhinitis, headache. Some of them present with the peculiar retroorbital pain and glandular enlargement. Severe forms of the disease are dengue hemorrhagic fever, dengue shock syndrome, whether it's plasma leakage, respiratory distress, and multi-organ failure. Again, the average onset of retinitis is 7 days post fever. Now, this mainly happens because of the immune-mediated pathophysiology. There is endothelial dysfunction causing immune complex deposition, and there is retinal capillary ischemia. And the visual recovery correlates with improvement of thrombocytopenia. These are the ocular features. And in posterior segment, we can also have features of acute macular neuropathy, which involves outer retinal involvement, and paracentral acute middle maculopathy, which involves the inner retinal involvement. And this has been found more commonly in young girls. The maculopathy as such has been differentiated into 3 types. Type 1 is diffuse retinal edema, type 2 is cystoid edema, and type 3 is the foveolitis. So diagnosis, the basic diagnosis for all these viral infections are PCR method, ELISA, and some peculiar finding investigations for certain diseases include, for West Nile, urine quantitative RT-PCR has shown more positive rates than serum PCR. And a new biomarker which has been found useful is the platelet distribution width. That is the size of the platelet. The higher the platelet distribution width, there are more chances of it being a West Nile virus infection. And in chikungunya, again, RT-PCR is more specific. And there is a specific test called TACMAN RT-PCR for chikungunya. Dengue, NS1 antigen plays an important role in the first week of illness. Now, most of these tests are useful only if they are done in the acute phase. Management, there are no specific antiviral agents as such for these organisms. So symptomatic treatment is done. In chikungunya, some of the cases have been treated with IV immunoglobulins, systemic corticosteroids, and periocular steroids wherever necessary. But we usually try to avoid periocular steroids as much as possible because we don't know the etiology as such. Prevention, again, we need to eliminate the breeding sites, measure to control mosquitoes covering of water tanks, cisterns, and other water storage equipment. And we also can introduce larvivorous fish in ornamental water tanks to avoid mosquito breeding. The last case, 42-year-old male came to us with defective vision since 10 days in both eyes. The vision was very poor, counting fingers close to face, and he gave a history of parotid swelling prior to defective vision. This was a clinical picture. This showed gyrate or cerebriform shaped lesions extending from the peripapillary region to the mid-periphery region. Now, we confirmed that it was indeed mumps by serology, IgG and IgM. And FFA did not show those lesions. And we treated the patient with IV methylprednisolone followed by very high dose oral steroids. But in spite of all the loading of steroids, and we also gave a course of valcyclovir, but in spite of all that, though the lesions disappeared after a period of a month, the vision did not improve because there was complete foveal atrophy. So this can be because of the direct viral invasion, or it could be an immune-mediated inflammation causing tissue damage. And because of the extensive vascular involvement and ischemic injury, the visual prognosis is quite bad. Apart from the retinitis, mumps can also cause dacryocystitis, conjunctivitis, corneal involvement, glaucoma, APM-PPE kind of picture, optic neuritis, and even ocular nerve palsies. Systemically, mumps can cause orchitis, uveitis, pancreatitis, and meningitis. Management, oral antiviral have been tried, systemic steroids have been tried, and some of the studies suggest hyperbaric oxygen therapy, where the patient is made to be in a chamber for around 1 hour, where they breathe in fresh oxygen, and the atmospheric pressure is 2.5 times more than the normal atmospheric pressure. And they say that it reduces inflammation, aiding in tissue repair and mitigating retinal ischemia, but it has not been found to be effective in improving the visual outcome so far. There is a recent case series which have compiled all the recent cases of mumps retinitis. And if you see that the vaccination part, now either the vaccination status was not known or they were not vaccinated. So this shows the importance of including mumps vaccination. And the recent guidelines of Indian Academy of Pediatrics says that the vaccine for mumps has actually been removed from the guidelines. It's an optional vaccine. And I think as ophthalmologists now we need to reinforce the vaccine back to the schedule, because prevention is the only way for this deadly infection. So in order to overcome all the backlogs of the diagnostics, the next generation sequencing is the metagenomic sequencing, which involves study of the structure and function of entire nucleotide sequence. That is, it reads out all the nucleotide sequence of a particular sample from microbial communities. And we can also take samples from tears, which could be non-invasive, and which can help us in diagnosing the microbial agent. And we do not need any primers, like as in RT-PCR, we usually need a primer to find out the organism, but here we do not need a primer. So whatever is said and done, prevention is always better than cure, and we need to follow the One Health approach of maintaining a sustainable ecosystem. Thank you.